Hello, everyone. Welcome to today's Biventricular webinar. My name is Michael Bangbishi. I'm the clinical research specialist for the Complex Biventricular Repair Program, and I also coordinate the weekly biventricular meetings. Today, I have with me Sarah Campos and Margaret Holland. And today we want to discuss the frequently asked questions about typical post-operative care when your child has a biventricular repair surgery at Boston Children's Hospital. We'll also talk about the biventricular repair program and discuss some practical details surrounding the surgery that are applicable to every patient. And then we will discuss additional expectations of what happens after your child has a biventricular repair. But before we move forward, let me just introduce our panelists. So Sarah is a surgical PA and the co-coordinator of the BIV program. She's trained in surgical fellowship and has had additional adult cardiac surgery experience prior to joining BCH 3 years ago. She works in the OR as well as in the CICU, and that's where patients recover after they have their BIV repair. And she's known for drawings of the repairs that help patients understand the operations. Thank you for joining us, Sarah.
Thanks for having me.
And I also have with me Margaret. She's a surgical PA as well. She's a senior coordinator of our BIV program. She has prior experience in pediatric cardiology as an RN, and after her PA training, worked for several years in the adult cardiac surgery. She's been at the BCH for 4 years, and she's as closely involved, similar to Sarah, in the OR and the ICU for the BIV patients. So thank you, Margaret, also for joining us today.
Thank you.
All right, so let's go straight to the topic for the day. So what to expect for the surgery and after? So, this question should be applicable to every patient. So like on the morning of the surgery, what happens, and from the time, the patient goes into the OR till when the parent sees the child again. So Margaret, take it from here.
Well, thank you so much, Sunny. Nice to meet all of you, and thank you for joining us today. We're really excited to speak with you and share with you some of the most frequently asked questions that we get. The morning of surgery when you arrive can be very stressful for families. So I think having a little bit of knowledge of what happens beforehand is really helpful for you. Typically, you're asked to arrive somewhere between 6 and 6:30 in the morning, so bright and early. Make sure you get plenty of sleep the night before. You will be met by an admitting nurse who will then take you to the preoperative area, and there your child will get checked in, get a wristband, all that fun stuff. We have a circulating nurse who comes from the operating room who will then also meet you, ask you some questions, and bring the anesthesia team as well. So from there, your child will be given a pre-medication that will help them feel relaxed. And I will say it's often easier on the patient than it is for the families because they're feeling great once they get that medication and once they're taken back to the operating room. And so you really have to focus on taking care of yourself at that point. It can be really stressful when your child is in surgery and you're the one in the waiting room sitting there and having to spend all day wondering how things are going. But they're asleep and they really don't remember much from the actual operation. So I definitely encourage families to make plans for lunch. I know it can be really hard, especially if you're worried about your child, but you are given a few phone calls when you are assigned a liaison. The liaison will touch base with you at certain points during the operation. So when it starts typically, and then when it ends. The exact times differ per child and when the operation is scheduled, but you do have a point of contact there. And the other question that we often get is related to the length of time to expect to be waiting around for your child. And again, this is very individual. So in general, the operations take between 4 to 8 hours, just a kind of an average. However, there's time before the surgery starts, which can last even up to a couple of hours. That is when anesthesia is putting in IVs and starting what's called induction, so the anesthetic process and intubating the child. So that can take a couple hours. So don't be surprised if it may take hours before you're given that phone call to let you know that the surgery has started. Afterwards as well, there can be a few hours delay time as your child gets stabilized in the intensive care unit. So probably the earliest you can expect to then be reunited with your loved one would be late afternoon. And that would be a pretty reasonable expectation. So you can make plans for the day and then come back later in the afternoon. But again, this is an average operation, so obviously that can change depending on the complexity of your child's operation.
Oh, thank you, Margaret. So I just want to ask, who can stay at the hospital?
Yeah, so another frequent question we get here. So the general rule essentially that applies to the ICU itself is that both parents / guardian are allowed to be with the child kind of throughout that whole preoperative process that Margaret just described. And then when your child makes it to the ICU, the general rule of thumb is that, again, it'll be dependent on kind of the stability of your child and what else is going on, but the general rule of thumb is 2 visitors at the bedside in the ICU. But again, certain exceptions can be made based on certain situations. And then overnight, one parent is allowed to stay with your child. And there's actually, we moved to a new building on a new unit. And there's actually a fairly nice sleep space for the parent that does stay over, in a nice area kind of in the back of the room that you can stay separate and hopefully get a good night's sleep, although I know that's hard with your child just getting surgery. But yeah, that's what's to be expected.
Okay, thank you, Sarah. Okay, so now, on the morning of the surgery, if like the parents is, preparing for like to come to the hospital for the morning of the surgery. Okay, so what do you think they should pack in the bag?
Very good question. Certain things that you could keep in mind would be practical, such as chargers for your phone. There are a few charging stations at the hospital that are available to you in the lobby, should you forget one, but it's better if you're able to bring your own with you. As Sarah mentioned, there is a place for you to sleep overnight. So if there's certain things that you prefer to have with you that we might not be able to provide, such as a particular pillow or blanket, then you are allowed to actually bring those in. Bring comfortable clothing as well, especially if you're waiting most of the day in the hospital. It can be a little chilly, so you might want to bring a jacket with you. Bring comfortable clothes that you can feel comfortable sitting in a chair for several hours in. There are many waiting rooms here in the hospital, as well as there's a nice cafeteria area with lots of seating that are options for waiting as well. The other thing that many families like to do is to bring familiar toys, even stuffed animals. That can be helpful not only morning of surgery, kind of like comfort items for your child, but they can also help acclimate to the ICU once you're there, whether it's a picture you can put at the end of the crib or some familiar toy that really brings them joy and can help in the recovery process. That is welcomed. If you don't have one, then our specialists in the hospital, often child life specialists, have the ability to help provide those for you. Pictures can also be something that the child life specialists put up on the front of the room to help staff become familiar with your child and to celebrate, them going through a difficult surgery. So if there are particular pictures that you like to bring or that you would like to have the staff recognize your child from a certain time or just to see how they are in their natural environment, that families really enjoy that. When your child starts to progress and they start to eat, some families find that bringing their own bottles or sippy cups is something that they haven't thought of before and often go out to get. If your child is used to something in particular, that is something that you could then work with the nutrition team to help provide.
Okay. Thank you so much for that, Margaret. So, okay, so while they're in the ICU, probably in the inpatient floor, can patients participate in the rounds, either ICU or in the ward rounds in the inpatient floor?
Yeah, so the answer is yes, and actually, we highly encourage families to be present for rounds. It just helps. Communication is key all across the hospital. So being available for rounds when the team comes by is highly encouraged. What a lot of parents don't understand is kind of the typical day in the ICU. So to kind of better understand that, typically the ICU teams start their rounds around 8:30, 9 o'clock in the morning, and usually they run through the day or through the morning until about 11 or noon. And kind of, I know that's a large window, but each ICU team has a certain number of patients to get to. So where your child will fall will vary. But during that time, a group of providers will kind of be huddled outside your child's room. And that team is comprised of the ICU attending, multiple fellows and nurse practitioners, the surgical team representatives, sometimes even a pharmacist, a dietitian, and if any consulting teams are involved in your child's care, sometimes they come around during that time too. And essentially what they do, or what rounds mean, is they kind of talk head to toe about your child and how they're doing, and essentially make a plan for the day. So a lot of what's said during rounds can be a lot of medical jargon to some families. So it's kind of have to suffer through a little bit, but always feeling free to chime in when you don't understand something, or you have a question of something, or want to clarify something. And then at the end of rounds, when they're made the plan for the day for your child, the ICU attending or the fellow or whoever's taking care of your child that day gives a good synopsis in layman's terms about what they have planned for the day. And another, not necessarily a question we get before surgery, but a realization families come to as they start to spend time in the ICU, is they realize that faces change a lot in the ICU. So the schedule we have is the ICU attending, or as we call the boss, for your child in the ICU, they're assigned to weekly schedules. So one ICU attending will be assigned to your child from Friday to Thursday of every week. And then at the end of that rotation, it'll be a new face, essentially making the decisions for your child that day. This is both a frustration, but also kind of a positive. We see with a lot of our families, it's frustrating because you feel like you're just starting to get to know a provider, and that provider is starting to know your child. But on the other hand too, sometimes a lot of the times fresh eyes or a new perspective coming into the team is also helpful for a lot of these patients as well. But when all's said and done, there's always background conversations, sign-offs. Everyone's up to date and kept up to date on the progress of your child and the plans that we've been working on. So although it is frustrating to see the change of faces, the plan is always talked about and everyone's kept in the loop. And something that you can ask for too that helps you participate in the ICU is asking when you do get confused or overwhelmed or are confused on who your care providers are. is feeling free to reach out to whoever's taking care of your child that day and ask kind of for a regroup or a team meeting, where we can get most of the providers in the same room. They can give you a synopsis of what's going on. You can ask any questions you have and kind of see all the faces of the team in one room. And this kind of bleeds into a continuity care program that we have if your child's here for quite a while, which a lot of our biventricular repair patients are, is having a few providers that you can name as, say, you know, one of the ICU doctors you worked really well with, you think that they really understood your needs and your child's needs, and you liked their practice. You can request that they are what's called your continuity care provider. And essentially they are, although they may not be day-to-day the head provider of your child, they're always kept in the background. Every team meeting that you have, they will be there to kind of help run the meeting. They'll touch base with you as a family, and whatever provider's taking care of your child that day. Even when they're not assigned to the ICU. Our ICU providers are very, very good and very passionate about any child that they're lucky enough to be asked to be heavily involved with their child. So yes, lots of ways. A short answer, just to bring it back to the question, is lots of ways to be involved in the ICU, and we heavily encourage it. The more we can understand your child and what they like, what they don't like, what's worked for them in the past, what hasn't worked, that's all helpful information that the ICU team can utilize in their plans that they're making for the day.
Yeah, thank you so much, Sarah, for that elaborate explanation. So now, once the child has BIV surgery, so what happens next? I understand that the child usually undergoes general anesthesia, and then they've been sedated, and and so on. So how long does this sedation last for, and then what happens the day after the surgery?
That's a really great question. And depending on the complexity of the biventricular repair, it can really vary, which can be frustrating for families because it's hard to have any kind of expectation when there's such variation. But I think when you take a heart that is used to single ventricle circulation and then you make many adjustments to then be a biventricular circulation, it can take quite some time, several days, before the body really adjusts to that. So it's not uncommon for patients to be sedated and intubated on the ventilator for 3 to 4 days after surgery. There's always attempts during that time to wean. However, it can be something that's required long-term as their body makes that adjustment. In terms of the surgery itself, many families have already been through the process of cardiac surgery. So you may ask if, is the same incision going to be used? And we very often do use the same incision. Sometimes it might be extended slightly because your child may have grown since their last surgery, but the same incision is typically used, and then the sternum is re-entered after it was previously entered for their first cardiac surgery. Coming out of the operating room, you can expect the standard chest tubes that are left for drainage purposes. On rare occasion, your child may be left with what we call an open chest, as lots of swelling can happen during surgery, and maybe the patient is more unstable when their chest is closed as they get used to the new circulation. So that can be a possibility as well. And then we always leave what are called pacing wires, which you may be familiar with, to help pace the heart if certain abnormal rhythms might develop, which can be common after surgery. There are certain lines that we may leave as well to monitor the hemodynamics of the heart that help us really understand if the body is adjusting to the physiology. They're called intracardiac lines. So intra meaning within, cardiac meaning heart. So these lines go directly into the heart. They can be useful for monitoring pressures, and then can also be used for administering medications as well. So your child may have lots of these coming out of the operating room, and then over the first week after surgery, we gradually start taking those out as they're not needed anymore. The other thing that may be surprising to families is that their child develops a fever quite quickly after surgery. We often see this in the BIV population, and still are actually researching why this is the case. But it's not uncommon to have to be placed on a cooling blanket to help bring the temperature to more normal thermic right after surgery. So that's something that can be expected as well.
Okay, thank you, Margaret, for that. So let's continue with our discussion. So what are your roles with the CICU team? Like, what are your relationship like with the team, and then basically your roles?
Yeah, so I know we've touched a bit upon kind of the ICU team itself and what's composed of the ICU team. And so Margaret and I, we're considered part of the surgical team. However, we do have a very close relationship with the ICU team. We're considered a consulting team to the ICU. So a common misunderstanding that some families express to us when they come out of surgery, it's a little bit of a handoff. So the surgeons in the operating room, they're doing what they're trained best to do is fixing the heart. And then we essentially transfer a lot of that care to the ICU team, because that's where they specialize the best, is taking care of these patients after we've essentially beat up the heart. So a common question I get from families is, oh, who is this doctor so-and-so? And we're like, oh, that's the intensivist or the ICU doctor. And they're confused. Oh, why isn't the surgeon, Dr. Amani or Dr. Fines, why aren't they running the rounds every morning? Why aren't they making all these decisions? And it's exactly because of that, because of the handoff over to the ICU team. So the primary day-to-day is run by that team, which is headed by the attending or the intensivist, all while making plans with us, the surgical team. So a lot of these discussions about what the best course of action is, how is this child progressing? Are they progressing as we expect? If they're not, what should we do next? If they are, how should we keep progressing them? A lot of those decisions are discussed every morning with the surgical team. So as a surgical team, we see every patient between 6 and 7 a.m. And we get updates from the ICU, hear their concerns, discuss those concerns with the surgeon, your child's surgeon. And with that, we make a plan with the surgeon themselves. And then once we've had a discussion with the surgeon, then we go back to the ICU team and say, we looked at your child, this is what the surgery team discussed, and this is how we think the course of action for today should be. And they take that and they incorporate that into their plan for the day that you may hear during their longer ICU rounds. And then as far as Margaret and myself being more designated as the biventricular repair PAs, so we have our normal clinical duties as a cardiac surgery PA. So our primary job is those rounds in the morning that I had mentioned, again, with all patients, not just the BIVs, but with special attention to the BIVs. We spend most of the day in the operating room, first or second assisting the surgeons. So you may not see us as readily available during the day, but typically when the operating rooms wrap up around 3-4 o'clock early afternoon, is kind of when we resurface and try to touch base with you guys, the biventricular repair families, and kind of make sure the ICU rounds went okay, make sure all your questions were answered, and see if you have any kind of lingering needs from a biventricular repair perspective. One of our biggest roles with the team is we try to touch base with you guys on the first day post-op. And we bring, which we'll get into a bit later, but we bring a drawing to you to kind of show you the repair that was done in the operating room. And kind of discuss exactly, I know it was probably relayed to you guys multiple times what's going to happen to your child in surgery, but to actually see it on paper and see what was actually done, we've heard it has been helpful to several families. So we'll try to find you on post-op day 1 and kind of explain exactly what happened, kind of show it to you, answer any kind of lingering question now that it's all said and done, and move forward from there. But ultimately, just to circle it back, Margaret and I just try to be a liaison and a communicator between that ICU team, you as the families, and then the surgeon, who obviously are very busy people as well. And just keep that communication going and making sure your child's progressing as we would expect.
Okay, so basically, everyone's timelines are different, right?
Mm-hmm.
Okay. So, Margaret, could you just tell us more about, in terms of timelines?
For sure, yes. As you said, everyone's timeline is different, so we can't give an exact length of time that you'll be in the hospital. But generally, families will stay in the ICU first. That's where your child goes immediately after surgery. And then once they have the breathing tube taken out, once they are starting to eat and really progressing, then they're moved to a step-down unit where you may stay for another week or sometimes even longer. If your child has had a lot of sedation during their ICU stay, sometimes it can take some time to actually wean them off of that. As well as feeding can be a big challenge for many of these patients as well. So we want to make sure that they're really doing well prior to being discharged. Families will, you do get an echocardiogram always before leaving the hospital, so we know how the repair looks before you walk out. But most families also find it really helpful to stay afterwards, after they've been discharged, sometimes up to 2 weeks, so that they have the option of scheduling appointments back at Boston Children's Hospital. In the event they have more questions, they can do their follow-up with cardiology as well as with our surgical PA that does our post-op follow-ups as well.
Okay, thank you, Margaret, for that. Okay, so now we've discussed when they come in, when they're in the hospital. Okay, so now what happens when they are after they've been discharged? So how does Boston Children's support a child once they are at home?
Yeah, so one of the newer things that we've started to implement, how I explained the drawings of your child's heart. Actually, we have some examples here. We can kind of just show up on the screen for you of something to expect. And there's many reasons kind of why we started these drawings. One, like I explained earlier, is so you as a parent or as a family can kind of understand your child's new anatomy and how it's unique to your child. Because what's unique about the biventricular repair program is it's not straightforward. You can't find a lot of these drawings or what it would look like in a textbook or online. So we try to essentially draw that out for you so you have a better understanding of kind of what's going inside your child's heart. And essentially my philosophy is the better you as a family, as a parent, understands your child's anatomy, the better it is for your child going forward. So anyone who meets your child, whether in a medical setting or not, you can be that voice that can explain these difficult surgeries that aren't seen very often. So we send you home with a printout of these drawings for both yourself, but also we encourage that you share it with your home cardiologist if you don't follow here at Boston Children's, your home pediatrician, so they can understand and take a look as well. And if they have any questions, to reach out to us. So that's something new we've been implementing as well, because one of the things we don't want is for you to go back home, and if that's far away from Boston Children's, and go back to your cardiologist and your pediatrician, and they don't understand at all what we have done for your child. So the better we can kind of, I guess, spread the word and make them understand, we're hoping the better follow-up we can have with your children going forward.
Okay, in addition to the drawings, we also have started administering surveys to the patients. Basically, this surveys is just our way of following up with our patients and just having like monitoring the patients over time and just knowing about their well-being, having a feeling about their well-being. And also this, as I said earlier, this survey started about late last year, and we usually send out these surveys every 6 months. So I can actually also show you just a draft of the survey. Okay, usually it doesn't take much of your time. It's probably within 10 minutes and you're done completing the survey. So this survey is just for us to just collect some information, as I said earlier, about the patient, some clinical information. As you can see here, you answer questions such as if the child gets, letting us know if the child is getting out of breath while doing some exercise or sporting activities, or whether there's chest pain or fast breathing or has a fast heartbeats. So it also contains some emotional questions that you would also want us to, that you also want to answer, and also anxiety kind of questions. And there are also parts of the survey also contains information about the clinical status of the child, or the current status of the child, whether the child is the oxygen saturation of the child, you let us know, or if the child is using oxygen at home, or if the child is gaining weight or using the feeding tube. You also want to know some information as regarding the medications the child is taking, and if the child is actually taking some medications, you also want to tell us the kind of medications that the child is taking. And also we also need to know, or you also want to know, have a feel if the child is also receiving medical follow-up care after the BIV survey. So basically these are just some of the things that you will come across in the survey. And as I said, it wouldn't take too much of your time. Within 10 minutes you're done. So we usually send the link to the survey into your email address, so you can actually fill it through from your phone. So it's very convenient to fill out. So that's a little bit about the BIV survey, and we'll encourage every one of you to help us fill it out. And even after 6 months, we also send it out, as I said earlier. So we also try and encourage you to also fill it out every 6 months when the surveys are being sent to you.
Yeah, thank you, Shani, for explaining the survey. And just to comment on that as well, kind of what we use the survey for. So I think Shani had mentioned that we send one kind of pre-op, how did your child look pre-op, and then 6 months after surgery, and then about a year after surgery. And Margaret and I are looking at these surveys, more importantly, the post-op surveys, so your 6 month and 1 year. And we're going through and looking what you have answered, and it helps us prompt important follow-up that may or may not be needed for your child with your providers here at Boston Children's. So for example, if some of those questions you answered coming back are concerning, well, it'll prompt a phone call from our end to you as the parents and kind of get more insight as to why those questions that you answered aren't as good as we would expect. And kind of once we get more answers from that end, we'll then reach over to your surgeon and your cardiologist here and say, hey, you know, so-and-so survey didn't look too great. We followed up and we do have some concerns. Would you like to see them back here for any imaging or follow-up, or can they follow up with their home provider? And again, just making sure that you're being taken care of even when you leave here at Boston Children's. But just to give insight on that, so that's another reason why these surveys, once you go home, are fairly important to us.
Okay, thank you so much, Sarah, for that. So we are about wrapping up our discussion. But before we do that, I just wanted to, ask one more question. And so, what's the future of the BIV program now?
Great question. We hope we can convert everyone to BIVs and no one has to go to Fontana Bay. No, but as far as the BIV program, and at least Margaret and I and Shani's role in it, is basically the biggest project we're working on is optimizing when you go home from a BIV repair. Kind of like we said throughout this whole discussion, it is a new and innovative procedure. A lot of smaller towns, countries, wherever you're coming from, may not hear or understand a lot of what we do here at the BIV program, or what concerns or what we would monitor kind of going forward. So one of our kind of biggest projects has been making sure you do have the support when you go home, and that you have people available to you and resources to get answers when there's questions, and to get follow-up when it's warranted. So one of the biggest things in the future going forward is actually hospital-wide here at Boston Children's. We have a merger with the electronic medical record and software called Epic Health, I believe, which parents, families may or may not be familiar with, but we're really excited about this as a hospital because it opens up more opportunities for us to better care for our patients. And one of those with patients going home is there's what's called the home health monitoring. So it provides a platform that essentially that there would be one place that you'd be able to message us if you have any concerns. So know, oh, what's their email? How do I get in contact with them? It hopefully will be one place that this survey that Shani went over will live. So you don't have to, figure out that link and remember that login and whatnot. And also we're in the works of discussing which patients would be beneficial to go home with devices such as an O2 probe or their blood pressure cuff, a scale, those sort of things to monitor vitals we look for in our BIV patients when they go home. And these devices, I bet actually many of you probably have these at home because you're great BIV families. But these devices would be special because they would communicate with our software here at Children. So every time you measure that SAT, we would see what's being measured in it on the intake form. So hopefully just making it easier to keep all of your child's kind of data in one place, make it easier for you guys at home to be able to communicate with us. And yeah, we're just excited for kind of the future of the BIV program and making sure you guys are all supported at home. And you can, again, spread the word of the biventricular repair So more institutions are familiar with it, even if they don't provide the services themselves, they can kind of better understand what to expect from a child who has had or is in the middle of biventricular conversion.
Yeah, so I can say the future looks bright for the BIVE program. So with this, we've come to the end of our biventricular webinar. I would like to say a big thank you to Margaret and Sarah for taking the time out to join us for this webinar session. And I also would like to thank all the parents watching online today. I would like you to go over to our biventricular website, and also to let you know that this recording will be added to our BCH YouTube page as well. So thank you all for joining and have a good day.
And thank
Thank
you,
you.
Shani.
Bye, everyone.
Bye.
Bye.